Before I begin, I do want to acknowledge that no matter where we are across Canada, we're on the traditional territories. Here at the University of Calgary, where this work is completed and the funding has come to, we are paying tribute to the traditional territories of the peoples of the Treaty 7, which includes the Blackfoot Confederacy, including the Siksika, the Piikani, and the Kainai First Nations, the Tsuut'ina First Nation, and the Stoney Nakoda, including the Chiniki, the Bearspaw, and the Goodstoney First Nations. City of Calgary is also home to Métis Nation of Alberta, Districts 5 and 6. And all of this is made possible by funding to the principal investigator, Dr. Cindy Barha. So a huge thank you to the Weston Family Foundation and the Canadian Institutes of Health Research. The funding came through the Brain Health and Cognitive Impairment in Aging Knowledge Mobilization Grant Competition. That's a mouthful, quite a lot. I'm sure the grant was even more that Cindy Barha had to write to get this funding. But it is all about mobilization, right? So it's bringing the evidence to you to help inform what you can do, in this case, around your brain health in particular. And then we've got the bonus tonight with our invited speaker from Ottawa to look at also your heart health. So it's all about movement. It's all about your heart health. We should actually all be back there exercising with that group. But, we're going to sit, listen, and learn, and hopefully take something from this to move through to how you can live well. I want to really thank on behalf of Dr. Barha, the individuals that have really helped pull this together. So at the back there, Joel, give a wave. Thank you to Joel, who has pulled together a lot of these pieces. And then our communications team at the University of Calgary, Stacy and Lee. I don't know where you are, sitting down maybe now. Oh, they're right there at the front. So thank you, huge thank you to them. And then all the red shirts, the student volunteers that are here. Thank you so much. All of this takes a lot of work to put it on. And thank you to Vivo for having us here and hosting the evening in this very unique space. I feel like I need a skateboard right here and do some tricks. I'd kill myself. But yeah, thank you to everybody. So just a couple of quick facts. We think of perimenopause as this endocrine transition state, but really it's also a neurological transition state. So we all know, right? All the women are nodding their heads looking at me like, tell me something I don't know, Nicole. Our brains change, right? We forget things. We feel like we might be losing it. We might be feeling more things like anxiety, stress, like just not coping as well. That's Dr. Cindy Barha's research and area, and I'll introduce her later before her talk. But that's one part of what we're going to talk about is, okay, where's the role for exercise? It is hot in here, isn't it? I see people waving their things. I'm like, I'm sweating. I don't think it's a hot flash, but maybe. Okay, so that's the first part of what we're talking. The second part is the impact on your cardiovascular system. So we know that prior to menopause, estrogens protect against heart disease, which is still the number one killer of women in Canada. Okay, so the heart implications from going through menopause. We know we have elevated risk as we go through that menopause journey, the pre, peri, post. Okay, so things to think about, and hopefully you're going to learn a lot this evening from really renowned speakers. Okay, it's my pleasure to welcome our first speaker this evening, Dr. Shafeena Premji. Shafeena, if you don't know her, Dr. Premji is a dedicated women's health advocate here in Calgary and a menopause specialist. She's a family physician and she's done additional fellowship designations with the Canadian College of Family Physicians and specifically in women's health. She's held since 2015 a Menopause Society certification and is the founder of not one, not two, but 3 specific women's health clinics here in Calgary. And I'll just put the push that we need, 30 more? 10 more? I don't know, a lot more to deal with this growing population of women who really want to know what can they do to take control of their health and wellness as they go through menopause. So she's got these clinics, which the last one was launched almost a year ago, right? March 2024. Dr. Premji also serves on the board of directors of the Canadian Menopause Society and the medical advisory board of the Menopause Foundation of Canada. So please join me in welcoming for our first talk, Dr. Premji, who's going to talk 2025 menopause, reclaimed, rebranded, redefined.
It's lovely to meet and see all of you tonight. And when Dr. Barha actually invited me to speak tonight, I actually thought there was going to be only 20 or 30 ladies here. So when I found out there was 300 people and this event was sold out, I was actually quite shocked, but also maybe not shocked, because providing menopause care for women over the last 12 years has really opened my eyes to how little we learn about our reproductive health. And as a medical student and as well a resident, going through my training, we learn about how to get pregnant, we learn how to not get pregnant, and then we're kind of left up not knowing anything about what happens beyond that point. And so it's been a huge learning curve for me as well, because I went through residency training with really no knowledge about menopause. And what really sparked my interest is that my mother went into menopause at 43, which is considered early. And as somebody who's always been so passionate about supporting women during the most vulnerable times in their life, understanding what a woman goes through both during the menopause transition and beyond is very important to me. The other thing also is that when we think about menopause, we think about periods and ovaries. But what I really want to highlight to you is that this is a multi-system change. And as a family physician, I have the privilege of not only managing that part of the reproductive changes that occur, but I'm also thinking about your breast health, your bone health, as well as your heart health. And so what I want to do over the next 20 minutes is really explain to you why the women of today's day and age feel so unvalidated and unsupported in the menopause transition, what's happened in the history of menopause, and why I called my talk the 2025 menopause is because I really want to do three things with you today. I want you to reclaim your menopause experience, meaning I want you to be able to feel confident in owning what that experience looks like for each one of you individually. I want to rebrand menopause because I want to change the perception that when we live beyond the age of our ovaries, that doesn't mean that we're past our prime, and that we have so much more to offer as women as we lead our lives beyond 50 or 51 when that final menstrual period occurs. And I want to redefine menopause because I want each one of you to feel a little bit more empowered after the end of this next hour. So here's something I hear from my patients every single day. I feel very alone in my menopause journey. And when we look at the Menopause Foundation of Canada, who actually did a landmark report in 2022, do you have any idea what that statistic is? What number or what percentage of women feel alone in the menopause journey? 50%. So 1 in 2 of you feel completely alone and unprepared. And so that's really quite a shocking number to me. And for us, representing half of the population, and there are also 10 million women above the age of 40 currently in Canada, to me, that's completely unacceptable. Here are some of the things my patients tell me. My doctor can't help me. So I hear that patients say, I love my family doctor. They have been able to help me through many different changes in life. But when it comes to menopause, I feel very unsupported and I feel very unvalidated. My family doesn't understand me. I had a patient yesterday in clinic tell me that sometimes when she wakes up in the morning, she has to tell her kids, today is one of those days. And what she means by that is stay away from me, because I can't explain what's going on in my body, but I can tell you I'm not good today, so give me that space. My coworkers can't find out. And what I mean by this is that we as women present ourselves to the workplace, and oftentimes during the menopause transition, we're at the peak of our careers. But our heavy periods, our soiled underwear, our soiled pants, our hot flushes, our migraines, we don't want anyone to know about that because we're ashamed. It equals, there's a stigma behind it. And we don't want our employers or managers to think that there's something wrong with us and that this is going to prevent us from moving up the scale in terms of our progression in our jobs. And there's also that stigma of just feeling afraid of getting old. And as a woman too, and understanding what my mom went through and witnessing her experience, we all feel the same way. And so what can we do to feel more empowered as we age and to think about it as a healthy aging versus something that we fear or that we feel that we're no longer of value to society? And as I said, aging is a privilege. Not everyone chooses to get pregnant and not everyone can get pregnant, but each one of us here individually, this is a universal experience. We may not have the genetic understanding of who and why we go through menopause. It varies points in our life, some women younger, some women older. But if we live that privilege of living long enough, each one of us is going to go through menopause. And so I really want to invite you to think about this as a time where you can become the CEO of your own health and to feel empowered towards healthy aging as well as a healthy menopause. Menopause is no longer an end of life event. And why do I say that? Because 100 years ago, it actually was. So if you look at this graph on the bottom, this is on the x-axis, this is the year, and on the y-axis is the age. And that dotted line right across the screen is the age of menopause. And you can see there's a cross between the age of menopause and the average life expectancy. So in the 1900s, which was really only 120 years ago, women were actually dying around the time that they were going into menopause. So this whole idea of being in menopause and living beyond the age of our ovaries is still quite a new concept. And that's why we as women need to understand that we are now spending 30 years or up to 40% of our life in this phase. And so being able to feel empowered and knowing what to do as we move forward is very, very important. Now, I want to take you back to the history of menopause. And the reason why is, a lot of us go to our healthcare providers and wonder, why is it that we actually have doctors who cannot help us? And I think that for a lot of you who may not know about the history, I think it's really valuable to understand this because it'll give you some perspective. So this is a scientific slide, and I don't expect you to understand any of this. But what I really want to highlight is that there was a very large study that was done about 30 years ago. It was called the Women's Health Initiative. Has anyone heard of that study? Okay, you've got about 20% of the hands, which is great. So what the study was looking at is in the early 1990s, even 1980s, Premarin, which is a form of estrogen, was the number one prescribed hormone in the US. In fact, the number one prescribed prescription in the US. And Premarin was considered the antidote of aging or the way for women to stay young. And there was this idea that perhaps if we gave all women estrogen, would we delay the onset of chronic medical conditions? So, for example, cancers, heart disease, blood clots, and strokes. So this was the largest study that was done on women who are asymptomatic between the ages of 50 and 79 to see that if we were to put women on estrogen without a uterus, so for women who had no uterus, estrogen alone, and for women who had an intact uterus, estrogen and progesterone in combination, would this prevent chronic medical conditions? And so what they did is they had two arms to this study, 16,000 women in the study who did not have a uterus, and around 11,000 women who did have a uterus. And they had a placebo arm and a treatment arm. So what this means is that there was two groups of women. They weren't sure which treatment that they were getting, so this was called a blinded study. And they looked to see what was the incidence of stroke, heart attack, blood clots, and cancers. Well, 6 years into the study, on July 7th, 2002, and I was unfortunately too young to remember this, in the news, my colleagues who were in practice at that time told me that this was the one time in their careers they had never received this many phone calls from women. And what happened was that this study was abruptly stopped. And the reason why this study was abruptly stopped was they were seeing an increase in breast cancers, in strokes, in heart attacks, and blood clots. And this was all over the news, and this is what I'm trying to highlight on this slide. So women were calling their family doctors and their gynecologists, what do I do with my hormone therapy? And this was the time where everyone began to be afraid of hormone therapy because now it was looking like it was actually going to cause all of these bad diseases. And so everyone was told, come off their hormone therapy. Gynecologists and family doctors stopped prescribing it, and essentially hormone therapy became buried. But what I want to highlight in this slide, again, this is a scientific slide, is that the problem with the way the information was publicized and put into the media was that they clumped all of the women between the ages of 50 and 79 into one lump sum. The other thing with this is that this was an oral estrogen that was in the study, And these were women who were all comers. So they were smokers, they were diabetics, some of them had already had a heart attack, and they were at least, the average woman was at least 10 years from her final period. So this is not the typical type of women that we now give hormone therapy to. So what I'm trying to demonstrate on this slide is that when they looked at the data again, they divided the data up between the 50-year-old women, the 60-year-old women, and the 70-year-old women. And as you can see, the blue represents heart disease, the yellow represents breast cancer, the red demonstrates stroke, and the green represents blood clot. And what we could see is that the risk of all of these events were actually occurring more so in the women in their 60s and 70s, and not so much in the women in their 50s, which is the demographic of women who are the most symptomatic with their vasomotor symptoms, who need the most amount of treatment. And so we now understood that actually hormone therapy can be very safe and beneficial for symptomatic women in their 50s, and it's more so the women in their 60s and 70s that we need to worry about. So this graph is demonstrating the absolute risk of any of these events per 10,000 women. So only 5 cases of breast cancer per 10,000 women for women who are on both estrogen and progesterone, and actually a decrease in breast cancer incidence for women on estrogen alone. So I'm really trying to highlight that this is the reason why there's such a fear around hormone therapy, is that the information was inappropriately publicized, and we now have very good understanding of this data, which is why it gives us comfort in prescribing it to the women who have an indication, who are symptomatic. So what's happened since 2002? Well, a lot of this is you may already know, but there's been a decline in hormone therapy. Prescriptions dropped by over 80%. There's an education gap. So the last 20 years of family doctors, endocrinologists, gynecologists who've gone through training have zero menopause education. Zero. And if anything, it's 1 hour. There is an increase in unregulated treatments because we've heard that maybe bioidentical or natural or compounded hormones are quote-unquote safer for you because the Health Canada approved products were no longer being prescribed by family doctors and gynecologists. And there's a risk with that because these are unregulated, not approved by Health Canada. There is an increase in compounded hormone therapies, which doesn't have any evidence for safety or efficacy, and we don't really know how these are prepared in compounding pharmacies. There's also some testosterone concerns because there's pellets being prescribed to patients. Testosterone is not even approved for women in Canada, and it only has some role for the low sexual desire. So there's a lot of misuse of this prescription as well. And now patients are paying a lot of money for unregulated prescriptions as well as testing and services because we don't have education in the Western healthcare system. So what I want to now, we've talked about the downwards effects. Now let's talk about the positives. So we're going to reclaim, rebrand, and redefine our menopause today. So let's talk about what actually menopause is. So menopause is really a decline in ovarian function. So like a lot of things that regenerate in our bodies, like our skin cells, hair cells, nails, and all of our organs, we are born with a finite number of eggs in our ovaries. We do not make more eggs. We do not create more eggs. The time in our life where we have the most number of eggs, can anybody guess? Yes. Period? In the embryo, that's correct. So you actually have the highest number of eggs in your ovaries when you're inside your mother's belly, around the 7th or 8th month of pregnancy. When you are born, you have anywhere from 300 to 600 eggs in your ovaries. When you hit puberty, that goes down to half. And by the time you actually go into menopause, you have about 1,000 eggs left. So an average woman goes through about 400 ovulations in her lifetime. So what's happening to all those other eggs? They're lost by attrition. So just through natural loss of that function. And so really menopause happens when we no longer are able to ovulate, and that is around the time of 50, 51 for the average woman, but it can range anywhere from 45 to 55. Perimenopause is still quite a new term, and perimenopause really is the transition to that final menstrual period, which for many women can last anywhere from 4 to 7 and sometimes even 10 years. So if a woman is starting to have symptoms in their early 40s, that potentially could be perimenopause. And the perimenopausal symptoms can be varied for each individual woman. Sometimes it's period cycle changes, and sometimes it's hot flushes, and sometimes it's mood changes, and sometimes it's sleep disturbances. Every woman's phenotype is very different. And so when your doctor tells you that you're not in perimenopause or that you need to wait for treatment until you are in menopause, I really want to invite you to advocate for yourself and say that that's not the case. And it's also a time where women are actually the most symptomatic. And then postmenopause is really from that day from your last period and for the rest of your life, which now we've talked about can be anywhere from 30 to 40 years. There's also this terminology of premature menopause or early menopause, as I talked about with regards to my mother. And this is important to know. And this is important to know because these women are at higher risk of developing long-term consequences from the absence of estrogen. So for women who go into menopause under 40, we call this premature menopause or premature ovarian insufficiency. And it's anywhere from 1 to 3% of women, which is actually quite a lot if you think about it. And early menopause occurs between 40 and 45, and this is 5% of women. The way this is diagnosed, it's not just based on periods, but when you have gone 4 or 5 months without a period and you're under 45, then we do blood work because we need to determine why you're not getting periods. Could it be early menopause or could it be something else? But this is the only time in a woman's menopause transition where we would want to do hormone level testing. And you can go into early menopause or premature menopause spontaneously, where we don't actually have a reason why it may have happened, but we do know that family history does correlate. So if your mother went into menopause early, you are at also higher risk, like myself. It can be because you've had surgery where you've had both of your ovaries removed. And remember, if you've had a hysterectomy where your uterus is removed, but the ovaries are still in place, this is not menopause. You have to have your ovaries bilaterally removed. It can be because of cancer treatment where you've gone through chemotherapy or radiation. Or it could be because you've had your ovaries removed for prophylactic reasons, meaning you may have a BRCA1 or 2 mutation where you have a higher risk of developing ovarian cancer and you have them removed for that reason. Now, these are the symptoms of menopause, which there are over 30 of them. And I really want to highlight here that this is a multi-system change, a neuro-reproductive change. Everything starts from the brain all the way down to your toes. We have estrogen receptors throughout our bodies. The vasomotor symptoms that we talk about, they're not in your head, but they originate in the head. And now we understand the pathophysiology behind it. And we now have new therapies that are specifically targeting the area in the brain where hot flushes originate. Sleep disruptions, depression, anxiety, cognitive changes, brain fog, word finding difficulties are very common symptoms of perimenopause and menopause. There's changes in your hair, skin, and nails, which can be very bothersome for a woman. There's the genitourinary syndrome of menopause. I'm not sure if you have heard of that term. It used to be called vaginal atrophy, but the genitourinary syndrome of menopause really highlights what happens to the changes in the vulvovaginal tract and your bladder. So we actually have estrogen receptors on our vulva, labia, vagina, urethra, and bladder. And so when we are going through menopause and beyond, actually these are some of the symptoms that are chronic and actually progress over time. So if we don't identify this early on and seek treatment, it can be very bothersome and affect quality of life and relationships. The cardiometabolic changes in terms of weight gain is a huge thing that many women experience, where they often tell me that they have made no changes to their diet or exercise, and they've gained 20 pounds in 1 year. This can be very, very psychologically bothersome to many patients. And we now understand the musculoskeletal syndrome of menopause, which we'll be exploring further today, I think. We have a paper on it that was published in 2024 that talks about the arthritis, the frozen shoulder, the new onset aches and pains that we have, where we go to our family doctor, we have investigations done, and we can't find any cause for it. We also understand the changes in our bone density and also now the loss of muscle mass, which is so important for us to understand as women. When women are experiencing this and they cannot show up to work, have to call in sick, or where 1 in 10 women actually need to quit their jobs and leave the workplace because of unmanaged symptoms of menopause, we have now identified that this is a $3.5 billion economic impact to our country every single year. So it's so important that we understand as women that if these symptoms are bothering you, that we seek help. And as a board member and medical advisory board of the Menopause Foundation of Canada, we now have a Menopause Works Here campaign where large companies like Sun Life are coming to join this campaign to help support their employees in their workplaces. So we're making positive changes. We just have a long ways to go. Getting to the end of my talk here, I really want to highlight there's a lot of misinformation online. We have so much information as women, but it's very hard to know and decipher who to trust and who not to trust. And so I want to highlight some evidence-based resources which are free online and that I can tell you are backed up by Canadian Menopause Society, the International Menopause Society, as well as the Menopause Society in the US, where this is backed based on research and good clinical trials. So you may want to take a picture of this slide. Our Canadian Menopause Society website, we have a lot of resources on that website for women. The Menopause Foundation of Canada has a symptom tracker and a step 1, 2, 3 about how to prepare for your doctor's appointment. The nq6.ca has two portions to that website. There's a portion specifically for you as a woman, and there's also a portion for your healthcare provider. If you feel comfortable enough asking your doctor who may feel uncomfortable with menopause, tell them about the NQ6 website. This is created by a Canadian family doctor. NQ stands for Menopause Quick 6. There's 6 easy questions that your family doctor that can ask you, and there's an actual algorithm that will walk your family doctor through the different steps to help you determine whether you are a candidate for hormone therapy or not. And this is all for free. It's a wonderful website. And in terms of podcasts, Melissa Grello is a journalist who is on social TV in Toronto, and she launched a podcast last year called Aging Powerfully with Melissa Grello. And it is full of information that's evidence-based, where she's interviewing the top menopause experts in Canada. It's very realistic, very practical, and I've listened to probably 90% of the podcast myself, and I continue to learn from that podcast. So I would highly recommend that to you. And finally, Dr. Jen Gunter, which I'm sure many of you know and who I know personally as well, has written this book, The Menopause Manifesto, which I believe is part of the door prizes for tonight. If you want to make sure that your Canadian doctors are also following guidelines, I also want to recommend the Menopause Society. They have videos for women, which are 5 minutes long. And what we recommend in Canada is in line with the American Menopause Society or the Menopause Society, the British Menopause Society, and the International Menopause Society. We could spend another hour talking about hormone therapy, but really what I want to highlight to you is that we now know that hormone therapy is the most effective treatment for the bothersome hot flushes and night sweats for women in perimenopause and menopause. And this is specifically for women who are under the age of 60. And now that you understand the data, you understand why I tell you it's under the age of 60 for initiation or within 10 years of her final period. And this is based on all the guidelines across the world. Now, a lot of patients feel and come to me and say, hey, my friend is on this, can I have the same thing? Or somebody will ask me, what's your favorite hormone therapy, or what's your favorite treatment? And what I tell patients is that one size doesn't fit all. Every woman who walks into my clinic, everything that I do is very individualized and personalized, where I'm looking at that woman in terms of her age, in terms of whether she is in peri or in menopause, what her personal risk factors are in terms of her heart health, bone health, and breast health. I do a very comprehensive assessment in terms of, have you had a mammogram? What is your family history of breast cancer? What happened to you when you were pregnant? Have you had mood disorders when you were younger? Really understanding you and your whole life context, because all of that matters in coming up with that right therapy. And it's important that we do shared decision making. So your preferences, your concerns are always a priority. And so what works for your friend or what works for somebody else may not be the best option for you. And I just want to close by saying that this is an amazing time in a woman's life. You're still vibrant, you're still healthy, and you have a wealth of knowledge and experience to offer. And I applaud each of you for spending your evening tonight to make yourselves advocates for your own health and CEOs of your own health. So I thank you.
Our next speaker is actually your true host of the evening, Dr. Cindy Barha. Cindy is an assistant professor in the Faculty of Kinesiology at the University of Calgary and is a professor of neuroscience. She holds a Canada Research Chair, Tier 2 in Neuroscience, Brain Health and Exercise, and was recently named the first Women's Brain Health Initiative Future Leader in Canadian Brain Research. Her translational research program looks at humans and rodent studies to understand why are females, in particular, at greater risk for developing dementia. Okay, and by focusing on both menopause and the role of pregnancy in history of brain aging. She also studies how exercise can be personalized and tailored to protect and promote brain health in midlife and in older age. So with that, I'm going to hand it over to Cindy for her talk. Thank you.
Thank you so much for that lovely introduction. And I don't have the background music, so I'm not going to do any dancing for you. So thank you all for coming today. This is an amazing turnout. This is the first time I've done a public event in Calgary. I've been a part of a few in Vancouver, and this is amazing. I'm so excited. So today I'm going to talk to you about menopause and the brain. I'm going to try to answer that question that's up there. What does exercise have to do with this? And the short answer, unfortunately, is we don't know yet. But what we do know is that physical inactivity is really a major risk factor for Alzheimer's disease. And this may be more so for females than it is for males. We also know that brain health is compromised during the menopause transition, and actually menopause is believed to be a sex-specific risk factor for Alzheimer's disease. And so I'm also going to talk today about why we think exercise is a key lifestyle strategy for protecting our brain health during our menopause transition. And so Dr. Premji did an amazing job explaining a few minutes ago about what is menopause and what happens with your hormones that are coming from your ovaries. So they start to dramatically fluctuate during the perimenopausal transition. And you can see that in this circle up here. Does that work? No, it does not. Okay. So the main hormone that we're actually concerned with is called estradiol. And it's the main type of estrogen that's in your body. We have lots of different types of estrogens. It's plural estrogens, and estradiol is the one we're mostly concerned with. And it really fluctuates during the perimenopausal transition. It slowly declines, but there's a lot of up and down, as you can see here. And so this fluctuation and that a gradual sort of decline in estradiol during perimenopause has a really incredible impact on the health of our brains. And this is because estradiol, that hormone, is neuroprotective. So in other words, this hormone keeps our brain cells healthy. It helps grow new brain cells in some areas of the brain. It also increases the size of some of the existing brain cells. Without estradiol, brain cells can start to shrink and even die off. So the perimenopausal period really is a critical window of vulnerability for our brains. In fact, many of us actually consider perimenopause not only to be an endocrine or reproductive transition state, but we also consider it to be a neurological or brain transition state. So we all sort of associate menopause with our ovaries, but when women say that they're having hot flashes, night sweats, insomnia, memory loss, depression, anxiety, these symptoms don't start in our ovaries, they start in our brains. So in up to about 80% of females, the perimenopausal transition can actually trigger a lot of these different co-occurring and overlapping symptoms that are listed here. And that does include vasomotor symptoms like Dr. Premji talked about. And so in many of these women, these symptoms do stabilize or they start to reduce after the onset of menopause when our hormone levels, we've become accustomed to that. But there's a lot of variability in the presence, the intensity, as well as the duration of these different symptoms. And actually, there's some research that suggests that the greater severity of these symptoms is actually been proposed as being a warning sign for an increased risk for Alzheimer's disease. So when I say these symptoms start in the brain, I really mean they start in the brain. So for example, estradiol, remember that hormone I talked about? It becomes dysregulated during the menopause transition, and it leads to this dysregulation of a part of the brain called the hypothalamus. So that's up here. Can't see my pointer, but the hypothalamus becomes dysregulated as well. And that's the part of the brain that actually is regulating body temperature. So those hot flashes that women are having, that's the hypothalamus. That increased depressive symptoms and the mood changes that some women have during perimenopause is related to estradiol's influence on a different part of the brain called the amygdala. And we think of that as the motion center of the brain. And for many women, they suffer from what we call brain fog, which is related to estradiol's influence on a part of the brain, my favorite part of the brain, called the hippocampus. And that's the memory center of your brain. So really, menopause is a neurological brain transition state. So what is brain fog? So it can manifest as difficulty with focusing, concentrating, issues with word finding, decrease in our attention span, more forgetfulness, reduced multitasking ability, and of course memory lapses. So just out of curiosity, how many people in the audience feel like they've experienced brain fog? Okay, that actually is a perfect segue into the actual studies that have been shown. So studies do actually show that there's a staggering 62% of perimenopausal and postmenopausal women that suffer from brain fog. And it's not an occasional inconvenience. This is a nearly daily challenge for that 62%. About a third of women experience brain fog occasionally or more on a sort of weekly basis. And it's only 7% of women that have never or hardly ever experienced brain fog. And so the research really does sort of indicate that this brain fog is related to our estradiol levels, so that hormone that I spoke about. So within the female brain, that reduction in estradiol has been linked to both structural changes and functional changes. And I know this looks like a really scary slide because it's got some imaging on it, but I'm going to walk you through it. So for example, using a type of brain imaging, so this is a technology that takes pictures of your brain called FDG PET, which we're using here, glucose metabolism, so that's what the brain uses for energy. That actually dramatically decreases as a person goes from premenopause to perimenopause. And you can see that in that first box that's up at the top in the red. And so in those brain images, the color red indicates high glucose or high energy use, and blue and green indicate lower glucose or lower energy use. And so I think you can see pretty clearly here in this individual who's going from pre to perimenopause, there's a lot less red. There's a reduction in glucose as they go into perimenopause. That reduction in brain energy production and glucose amounts during that transition is actually somewhat similar to what we see in early stages of Alzheimer's disease. And if you look at an age-matched male, we don't see very much change in glucose. In fact, we see no change in glucose over that same period of time, so over 3 years. So that decline in estradiol that we're seeing during the perimenopause also leads to our brain cells starting to sort of slow down and age faster, leading to reductions in volume of different brain areas that have been implicated in learning and memory and in thinking. As well, during perimenopause, for some females, the formation of Alzheimer's disease, a neuropathology, begins. And so specifically what we see is increased amounts of two different proteins, amyloid and tau. And these are two hallmarks of Alzheimer's disease. And so these are bad proteins. Tau and amyloid in this case are bad. And what we see is really high levels of both of those bad proteins in the brains of patients that had been diagnosed with Alzheimer's disease. But I do want to, sounds like a lot of bad news, but I do want to point out there's a lot of variation in how severe these changes in the brain are happening. So some women only show small degrees of changes. And just because having these proteins in your brain during menopause, that doesn't mean that you have Alzheimer's disease. But what this shows is that how deeply menopause is actually influencing our brains. And so that loss in estradiol, that loss in neuroprotection during perimenopause, and all those changes that I just spoke about in the brain, this does lead to an increased risk of dementia in women after menopause. So across the globe, 2/3 of all people that have Alzheimer's disease are female, and females also have a greater lifetime risk of developing Alzheimer's. Females show greater cognitive decline after they've been diagnosed, so they show declines in thinking and memory, ability compared to males. They also show more neuropathology in the brain compared to males, so they have higher levels of those bad proteins, tau and amyloid. However, while we do still think that menopause is a sex-specific risk factor for Alzheimer's, menopause itself isn't causing Alzheimer's disease. Menopause, particularly if it occurs prematurely or surgically, does seem to put the brain at risk, but you need the presence of additional dementia risk factors. So, for example, pregnancy history, so this is the number and the health status of previous pregnancies, does seem to be a sex-specific risk factor for Alzheimer's disease in women. With 5 or more pregnancies and 0 previous pregnancies, both having been associated with an increased risk for Alzheimer's disease. Another risk factor for Alzheimer's disease that has a stronger effect in females is the ApoE4 gene variant. Okay, so some of you may have heard about ApoE4 in the news recently. So every one of us carries this gene in our DNA. It's called the ApoE gene, but it comes in different variants or different forms. Actually, it comes in 3 different forms. So the E3 variant is the most common. Almost all of us have that one, and it's neutral when it comes to brain health and dementia. The E2 variant, much less common. If anything, that's associated with brain protection and a decreased risk for Alzheimer's. And then there's that E4 variant. It's one of the greatest genetic risk factors for developing Alzheimer's disease. And so a few years ago, the great actor, Chris Hemsworth, and I think this is lovely because it's a massive picture of him, this is AKA Thor, told the world that he actually carries 2 copies of the E4 form, one from each of his parents. So he's actually 4 times more likely to develop Alzheimer's disease as he gets older compared to someone that has that E3 neutral form. But to me, what I think was really interesting is that if Thor had actually been a female and he had 2 copies of the E4 allele, then Thor would actually be 12 times more likely to develop Alzheimer's disease. If you carry 1 copy of E4, that's related to 2 times greater risk in males and 8 times greater risk in females. And so the hormonal changes and those brain changes that are occurring during menopause, when those are combined with other risk factors like pregnancy history and genetics, as well as an unhealthy lifestyle, that will increase your risk for dementia. And so up here I've put physical inactivity during midlife. This is an established risk factor for dementia. And there's some research that actually suggests that this might be more so for females. So inactivity, physical inactivity might increase dementia risk more in females than it does in males. And importantly, this risk factor, it's modifiable, meaning that we can change it, right? And so what's one of the best ways to increase physical inactivity? Exercising more, right? So as I said, physical inactivity is one of the main modifiable risk factors for dementia. And research in older adults, so over 65, indicates that exercise does play a really important role in both the protection and treatment of cognitive impairment, so declines in thinking and memory. And my lab actually showed that this may be particularly true for women. So for example, we've consistently seen across different populations a sex difference favoring postmenopausal women in the magnitude of the exercise benefits for cognition in older age. So in other words, we see greater improvements in thinking ability in postmenopausal women after exercise compared to men. And so our work really seems to indicate that, at least in postmenopausal women, that exercise is a really potent way to protect your brain health. But what about perimenopausal women? So I said before that perimenopause is a critical window of vulnerability for brain health due to all those hormonal changes. But it's also a critical window for intervention because we may be able to actually intervene with lifestyle changes or other therapies that can stop those brain changes from becoming worse. So what actually does the literature say about exercise's effects on the brain and cognition during perimenopause? So I had my lab start scouring the literature to find all of the studies that have been done looking at this. And they found 3 studies. That's it. 3 studies that have been done, that have been published, that were looking specifically in perimenopausal women and looking at cognition and exercise or physical activity. That's it, just 3. So the students have actually created this really nice infographic that's up here about the review of the perimenopausal literature. So if you're interested, you can grab a copy on your way out. We have some of these out there. And so I'm just going to briefly talk about those 3 studies. So what they found was that one study looked at the relationship between self-reported levels of physical activity during perimenopause and the relationship of cognition. And they found that these were not significantly associated. But this is self-report, and it's not a very good way of measuring physical activity because there's a tendency for people to either over or under-report. We're just not very good at judging our own physical activity levels, it turns out. Another study found that a single session of high-intensity interval training did improve thinking skills, but not all of them. And the last study found that a single session of aerobic training, so running, also improved some thinking skills, but not all of them. So unfortunately, at this stage, we only really have 3 somewhat poor quality studies that we can draw evidence for. So we really don't know what the optimal exercise prescription is for maintaining brain health in perimenopause. So I'm sorry about that. But what we do know is that you don't need to be out there training to run a marathon or trying to look like Dwayne "The Rock" Johnson. Also happy that I got to put his picture up. We know that as little as 10 minutes of brisk walking in older age is beneficial for brain function. We also know that meeting the international exercise recommendations during midlife, so during middle age, that 20 years, is really important, at least in terms of maintaining a health-related quality of life. We don't know about cognition because that study hasn't been done. So I'm just going to quickly highlight this fairly new study that looked at whether meeting the World Health Organization's physical activity guidelines of doing at least 150 to 300 minutes of moderate intensity exercise or doing 75 minutes to 150 minutes of vigorous physical activity per week during the midlife, whether that was better for quality of life compared to not meeting those physical activity guidelines. They also wanted to look at whether meeting those guidelines later in life, so meeting those physical activity guidelines at the age of 55, also influenced quality of life in older age. And so they're looking at quality of life when these women are between 68 and 73 years of age. And what they found was that the women who consistently met those physical activity guidelines during their midlife, so consistently exercised during that 15-20 year period, they had better quality of life in older age compared to the women that didn't meet those physical activity guidelines. But what I think is really important is that those who only started meeting those physical activity guidelines at age 55 also had better quality of life in older age. So it's never too late to start consistently exercising. And I'm going to leave it at that because I think Dr. Reed's going to give us some very powerful and uplifting tips for exercise. So I'll leave it at that.
I'm very excited to hear our last speaker this evening, and there is no relation, but Dr. Jennifer Reed has joined us today all the way from the University of Ottawa. Dr. Reed is the Program Chair of Cardiac Rehabilitation at the University of Ottawa Heart Institute, as well as a scientist and Director of the Exercise, Physiology, and Cardiovascular Health Lab. She is an Associate Professor in the School of Epidemiology and Public Health in the Faculty of Medicine at the University of Ottawa, Adjunct Professor in the School of Human Kinetics in the Faculty of Health Sciences, and a registered kinesiologist with the College of Kinesiologists of Ontario. Her research really looks at the role of exercise and physical activity to both prevent and manage cardiovascular disease, and she has a particular interest within this work at looking at women's heart health. So with that, I'd like to welcome Dr. Reed to talk about exercise and heart health during and after menopause.
So I'm from Ottawa, and honestly, it has been the warmest welcome from both people and weather, as I mentioned, so I'm honored to be here this evening. Our plan for the next 15 or so minutes is going to focus on women's heart health, what everyone should know. Let's talk menopause, what it is, and what are the symptoms, and I'll try not to overlap too much of the excellent information that's already been shared this evening. And then finally, probably the area you're most interested in is how can exercise help to move you through menopause? I always like to start off speaking at such events with laying the groundwork with some statistics or numbers for you to think about and also to reflect on. And so heart disease is the leading cause of premature death among women in Canada. On average, 32,000 women die annually from heart disease and stroke combined. Now, when you look at those statistics, you probably immediately think of breast cancer. We often hear as breast cancer being the greatest threat to women's health. But when it comes to premature death, it's cardiovascular disease for women, not breast cancer. More than 50% of Canadian women typically lack knowledge of heart disease risk factors, meaning they're unaware of their own risk or what constitutes risk factors for cardiovascular disease. When we look across Canada, the picture is the same for Alberta. And this particular figure map is identifying the number of new cases of ischemic heart disease for women over the age of 20 when it's standardized for a number of 100,000 females. And what we see here, based on the shadings of green, darker green means higher numbers, higher incidence rate. And we see that for Alberta and BC, those incidence rates, those number of new cases for cardiovascular disease is higher than in other parts of the country. But regardless of where you live in Canada, it's still a major concern. I want to spend the next few seconds sharing with you what are risk factors for cardiovascular disease, when did they begin, and when did they end. So we've already known so far that clearly menopause is a risk factor for cardiovascular disease, but our risk begins with age of menarche, onset of menses, and carries out throughout one's lifespan. And across that time frame, we also have traditional risk factors that apply to both men and women, and that includes regular smoking, high blood pressure, diabetes, high cholesterol levels, poor dietary choices or unhealthy choices, being sedentary, meaning spending a lot of time sitting or standing, and stress, poor mental health. Those are traditional risk factors that exist for both males and females, but this figure specifically highlights those that are unique to women, and the focus for this evening is menopause. I'm not going to spend a lot of time identifying or describing what menopause is. I think you've heard from two other excellent speakers, but I do like to share this figure because there's a visual here for me. Over the course of one's lifespan, with women in particular, we see this decline in estrogen levels. And I like this particular infographic because it shows the decline. You can see the depletion of estrogen over the course of one's life. And it's that decreased decline in estrogen which contributes or partly contributes to your increased risk of cardiovascular disease. You're probably more well aware of the symptoms for menopause than I am, but my day will come, as it will come for everyone. And the reason I show this infographic is, again, to show the diversity in symptoms. We aren't simply speaking to one or two symptoms, we're speaking to many symptoms. And it's to give you an idea of how varied these symptoms are that can exist between women. And not only how varied, but the severity of these symptoms will also differ. So my role as your last speaker is to focus on physical activity and exercise, and specifically to look at the evidence-based strategies that are used to perhaps reduce or manage menopausal symptoms. It's not every woman will choose to take hormonal replacement therapy or be advised to, and that's on an individual level with your physician. And in addition to those medications, whether you are or are not taking them, there are other lifestyle options that you can look to help manage your menopausal symptoms. So I plan for the next few minutes to walk you through the literature, the scientific literature, to give you an idea of what's been published and the findings to date. So we're going to start off in 2019, and this is going to be a bit of a whistle-stop tour because you'll see in the end why it's going to be a whistle-stop tour. But in 2019, there was a study that evaluated the relationship, the association between physical activity levels and how you spend time being physically active and menopausal symptoms. 305 women in Poland, Polish women, were recruited between the ages of 40 and 65, and these women completed questionnaires assessing their physical activity levels, their menopausal status, and their menopausal symptoms. And what this particular study showed is that those that engaged in higher levels of physical activity, high and moderate levels of physical activity, presented with less severe menopausal symptoms. So that was 2009, one study from Poland. Then we move ahead to 2022, and there was a study, a publication, where researchers, investigators interviewed women about their menopausal symptoms. And this term vasomotor has been used quite a bit this evening, and that's really our scientific medical terminology for hot flushes and night sweats. So in case that wasn't clear before, we'll just reiterate all of these wonderful symptoms that are associated with menopause. But in this particular study, they interviewed women about their thoughts on physical activity and menopausal symptoms. And the blue boxes, to walk you through this, the blue boxes are the summary statements that you'll find within the publication, and the red boxes are direct quotes from women that are in the publication that support the summary statements. So the relationship or their thoughts on physical activity and managing menopausal symptoms, women talk positively about physical activity, PA, as a treatment for their menopausal symptoms. They found that regular physical activity helped to improve their sleep, physical health, and psychological well-being. And many commented they would prefer their physicians to discuss physical activity as a possible treatment for their hot flushes and night sweats before offering medication. So this is when we went directly to the women who are experiencing these symptoms and asking them for their thoughts on using physical activity as a management tool. This is the most recent review on the role of physical activity or exercise on hot flushes and night sweats in menopausal women. It's a review, meaning it scoured the literature looking at all clinical trials, randomized control trials, to look at the effect of exercise on the frequency, how often women are experiencing hot flushes and night sweats. In this review, there were 7 studies included, and those 7 studies had 436 women engaging in regular physical activity, and then other groups of women were not engaging in any form of structured or recommended physical activity. 504 women across 7 studies were not engaged in a physical activity program. And these are from randomized control trials, and it's really a sophisticated language for saying that, like the flip of a coin, women were either randomly assigned to participate in a physical activity program, or they were randomly assigned, like the flip of a coin, to not participate in a structured supervised program. And what they found that there was no difference, meaning when you compared the women that engaged in regular physical activity, structured physical activity versus not, there were no differences in the frequency, how often they experienced hot flushes and night sweats. But then they went on to explore the severity, how severe the symptoms were. And in this case, they found 12 studies with 712 women engaging in physical activity and 12 studies with 713 women not engaging in regular physical activity programming. And this is where they found a positive effect of exercise on the severity of hot flushes and night sweats. But the evidence was of low quality. There was uncertainty with the evidence. And there's many reasons why we can be uncertain about the level of evidence. It can be based on the size of the clinical trial. It can be based on the methods that are used to conduct that clinical trial. There's a myriad of reasons, and I'm happy to answer those during the Q&A. But I share this because, one, it's the most recent review that exists in literature on the topic, and 2, it highlights the uncertainty or the lower quality of evidence. And the reason I raised this review is because I think in events like this, it's really important to communicate and have these discussions about how you can advance women's heart health research. What can you do as a woman sitting in this audience to advance the science in this area? And so there are 2 recommendations I would give. General recommendations is, 1, be a voice. And that is, become involved in designing research questions, become involved in the management of research projects. There are often, both at this University of Calgary and other research institutes and across Canada and North America and the globe, you'll find what we call patient partners or citizen partners. Those are individuals that want to get involved in the research process. 2 is, become a source of data for these clinical trials. In my area of research, where it's exercise-based rehabilitation for women with cardiovascular disease, we see much fewer women in clinical trials and in our programming. Typically, about a third are women and 2/3 are men when we look at exercise-based cardiac rehabilitation. So the way to have more data for women is to find ways to engage women and have women participate in research. So if you ever have the opportunity, use your voice and become part of the planning process or become a very important data point in these clinical trials. So you may have just heard, well, there isn't a lot of evidence, there's not a lot of strength in the evidence, so why bother being physically active to reduce the severity or potentially not impact the frequency of my menopausal symptoms? And so with that, I'm going to share a hopefully very important message. Whether we're talking menopause or cardiovascular health or brain health, exercise has been demonstrated for decades to be an effective tool to manage your health. This is where you are directly in control and can use exercise as a tool for not only cardiovascular disease prevention, but also management. So I'm going to light up the board here with all of the benefits of physical activity. If you ever find me on the street, you will probably have a difficult time getting me to stop talking about physical activity and chronic disease management. So we're going to light the board up. So what does physical activity do? And this is based on decades of research. One, physical activity can improve your functional capacity, which is just a more technical term for fitness levels. It can improve your cardiovascular health. It can enable you to manage your weight, improve bone mineral density, your bone health, immunity. It also can impact your mental and emotional well-being, your sexual function, your interpersonal connectedness, your sleep quality, and your cognitive function, brain health. These are all the demonstrated and documented benefits of regular physical activity. So there's growing research showing the benefits of physical activity on managing the severity of symptoms for menopause, but there's also decades of research showing the benefits of physical activity on all facets of your health. These next two slides are going to highlight the Canadian 24-hour movement guidelines. These are clinical guidelines, these are recommendations for all Canadians to be active and involved in physical activity. And there are guidelines, physical activity guidelines for nearly every country across the globe. So if you are between the ages of 18 and 64, we recommend that you engage in at least 150 minutes of moderate to vigorous intensity physical activity every week. And you may say, well, this week I only engaged in 5 minutes or 10 minutes, so I probably didn't achieve the benefits. That's not true. Every single minute you spend engaging in regular physical activity contributes to your overall health. We also have recommendations about sleep, and that is achieving 7 to 9 hours of quality sleep a night and reducing your sedentary time, meaning time spent sitting or lying down, to less than 8 hours a day. And it may be, well, you're on the big screen up here, so you can see these numbers much better than I can from here. If we move to those that are 65 years plus, there are also recommendations. Still 150 minutes per week of moderate to vigorous intensity physical activity, both regardless of the age, 2 bouts per week of strength training, acquiring 7 to 8 hours in this case of quality sleep, and trying to limit your sedentary time, what we're doing right now, sitting. And so just being aware that we want to move more, sit less, strive for 150 minutes per week, engage in 2 bouts of strength training a week, and as we age, try to incorporate more balanced activities into our day-to-day life. So we recently completed this large project with the Canadian Public Health Agency of Canada. We call it FAC or PHAC. But I wanted to ask a really fundamental question. Are the physical activity levels of those with cardiovascular disease any different than those individuals without cardiovascular disease? Are those with cardiovascular disease different or special in any capacity? And so we set out on using all the large databases that exist that are managed by the Canadian Public Health Agency of Canada, and included over 7,000 individuals, some presenting with cardiovascular disease and some without. And what we showed in this study that is just been published in the Canadian Journal of Cardiology, it's open access, which is just a special term for saying it's available for anyone to download and read. It means it's not behind a paywall, there is no fee, you can download it, you can read it, you can use it as a fire starter as you get close to the winter season here, whenever it comes your way. But what we found in this study is that only 29% of adults living with cardiovascular disease were meeting the physical activity recommendations of 150 minutes per week, and only 15% were meeting the sedentary behavior recommendations, meaning less than 8 hours a day being sedentary. So a very small percentage of those living with cardiovascular disease are meeting the physical activity and the sedentary behavior guidelines. And this is really important because I've just shared with you the impact of cardiovascular disease on one's life, the number of individuals that are at risk for cardiovascular disease, and the beneficial role of physical activity in managing all of our systems. So if we look beyond Canada, what are the physical inactivity, meaning not meeting guidelines? And there was a publication a few years ago in the Lancet, which is one of our very highly reputable scientific journals that exist in literature, that showed worldwide, over the past 22 years, the prevalence of physical inactivity, meaning not meeting these guidelines, was 31% across the globe. And that number is actually increased in 2022 versus 2020 and the year 2000. So the rates of physical inactivity are increasing, meaning people are less and less physically active based on this particular study and how they evaluated physical activity. Canada, the US, North America, those that are shaded in this light orange, that means that their prevalence of physical inactivity, meaning not meeting the guidelines, was between 30 and 39.9%. There are targets to reduce our rates of physical inactivity by 15% by the year 2030. And what I can unfortunately share with you is that we are most certainly not on track to meet improvements in physical activity levels. We are not on track with a good level of certainty to be increasing our physical activity levels. So that's why I'm here, hopefully. And so I want to take a minute just to go through a fun little exercise. So if math is not your strongest suit, pull out your phone, grab your calculator. I promise this is not a calculus class or a math class. This is for you to do an assessment to see where you are. So I'm going to ask you a series of questions. So we're going to fill in the boxes. So the first box, during a typical week, 7 days, how many days do you do moderate to vigorous intensity aerobic physical activity? A lot of words to mean physical activity that's difficult for you or moderately difficult. Brisk walking, cycling, jogging, Zumba, whatever your sport or activity may be. How many days a week do you engage in this form of activity? Okay, do you have the number in your head or you've got it on your phone? Okay. Question 2. On those days, do you do, on days that you do at least moderate intensity physical activity, for how many minutes do you do this activity? So on average, how many minutes do you do these activities? So you've got one number, which is how many days a week, and you've got the second number, which is on average for how many minutes. Okay, this is where the math comes in. You're going to multiply those two numbers together. You've got it in your head? Okay, or you've got it on your calculator? Okay, so if your number is over 150, you're meeting the weekly Canadian physical activity guidelines. If your number is lower, that's okay. You're one of many Canadians and one of many global citizens that are likely not meeting it. But hopefully in your mind is the comment or the statement that I made that every minute of physical activity is beneficial. Every minute. So if you're not at 150, you have an idea of how much more work you need to do. And if you are, it doesn't mean you necessarily stop there. You can do more. And so I want to share 2 final slides. These are my official, rigorous physical activity recommendations I like to give at these events and every event. Some is better than none, and more is better than some. So if you have a number greater than 0, that means you move to the second part of the sentence, more is better than some. And if you're at 0, just have to do some. Some is better than none. So some is better than none, and more is better than some. And how do we get there? How do we increase our minutes? Well, the 3 Fs. There could be 4 Fs, but we're at 3 Fs when we're talking about symptoms in menopause. And that is fun, feasible, and forever. Pick an activity that's fun, that you enjoy. Don't make this more difficult on yourself. Pick something that you're moving and you enjoy. Something that's feasible. Perhaps it's close to where you live. Perhaps it doesn't cost a lot for you to get involved. Perhaps it's a YouTube channel and you're doing step dancing in your garage. Whatever it is, it needs to be feasible. And the last is pick an activity that you could see yourself doing forever. And those are the 3 F's of physical activity. We do not have to overprescribe, medicalize physical activity. Fun, feasible, forever. And with that, hopefully you will engage in just a little bit more physical activity to bring you to 150 minutes. And if you get there, just keep going, because all physical activity is beneficial for your heart health and your brain health. And with that, this is cold, frigid Ottawa, not today. That's my email address. I'm very slow responding at emails, but you can also find me on Blue Sky Social or LinkedIn or elsewhere. So thank you so much. Truly an honor to be here tonight, and I hope you enjoyed it.